Okay, got it. Got it. Hello, everyone, wherever you're tuning in from. Welcome to the EMS Eco Session. And this is the 115th session of the 8th sitting of 2026. And everybody is welcome. And before we start off to dive into our session today, I would like to introduce the panelists today, and I would give them a chance to introduce themselves, starting with the team that is online. Dr. Anna, please unmute and speak to us.
A very good afternoon, everyone. Thank you all for joining in today for our session. We are always glad to have you here to learn and share knowledge together. My name is Anna Kaguna. I'm an emergency physician working with Malago National Referral, specifically the medical emergency. I'm glad to be here.
Thank you so much, Dr. Anna Kaguna. We have another key person who is one of the members of this panel. Dr. Marion.
Hello, everyone. Good afternoon. My name is Dr. Marion Nachayune. I'm a general surgeon. I work with the Ministry of Health under the Emergency Medical Services Department. I'm excited about this topic, and I hope we all enjoy this time, these 2 hours. Thank you, and over.
Yes, thank you so much, Dr. Marion. Back to where we are physically, we have, another OBS and Gyne guru in this Codem Studios. Dr. Peter, kindly speak to the participants.
Hello, good afternoon, everyone. Dr. Peter Wanyere is my name, OBS Gyne, Bari Regional Referral Hospital. Thank you.
Yeah, thank you so much. Last but not least, maybe before I introduce my last panelist, you need to know who I am. My name is Tom Chove. I work with Association of Ambulance Professionals Uganda in the pre-hospital area, and it's my honor and privilege to also moderate this session and introduce to you my last panelist. Kindly introduce yourself to the world.
Yes, thank you, our president, and thank you all members who have logged in. I'm Dr. J.B. Wanyaye Nambohe. I'm the Commissioner for Emergency Medical Services. You are all welcome to this session today, which is to discuss referral system, very, very dear area. Thank you.
Yeah, thank you so much, Commissioner Dr. JB. And you realize that according to this panel of experts, they wouldn't have any other person to talk about Uganda's referral processes and protocols other than the people who are on here today. Would like to also look at what are the expectations. I know most of us have already mentioned what you expect from this wonderful session, today's session, and I want to appreciate that most of you wanted to know more about Uganda's referral processes and what protocols are available. Looking at also something that is so key right now. Also, some people wanted to look at what is actually available in terms of Ebola response. We'll find ways on how to, my panelists would be able to partake of this, but also We welcome all your questions at the appropriate time. During this session, we have key presentation. A key presenter for today will be, a guest presenter will be Dr. Anna Kaguna, and in a few moments from now, we'll allow her to get us the case presentation, and then we dive into today's session. Dr. Kaguna, if you're ready to present, you're highly welcome. Dr. Anna?
Good afternoon once again. Thank you, Mr. Tom. I'm here to present a case that we received at the medical emergency unit. And just a disclaimer, this case is not to point a finger to anyone. It's just to help us see the loopholes in our system or in our practice so that we can learn from these cases and make our care better. And then a second disclaimer is, for purposes of not pointing fingers, I will not disclose the address of this referral, and neither will I disclose the referring facility. They'll stay anonymous. Okay, so I'm presenting MH, a 41-year-old male who is a farmer, brought into the medical emergency on the 12th of May, 2026 in the afternoon at about 2:30 p.m. He was brought in by ambulance, which had two providers, two nursing students, and upon arrival, we had a referral note that read 41-year-old male being referred to Mulago National Referral following a one-day history of reduced levels of consciousness. He was a non-DM hypertensive on treatment, and he was quite well until a day prior to showing up at the referring facility. And the attendants reported he had a sudden loss of consciousness for about 2 to 3 hours. This loss of consciousness had been preceded by dizziness, and then afterwards the patient collapsed. They reported no history of convulsions, nausea, or vomiting. And just to put this into context, the patient was on treatments, and the current regimen was metformin 1 gram BD, glibenclamide 10 milligrams, and was on losartan H 50, 12.5. So the referring facility gave us findings from their examination, and they found a middle-aged man who was semi-conscious, who was not pale, not dehydrated, not jaundiced. And GCS upon assessment had a GCS of 10 out of 15, where they scored the eye opening to be to pain, had a confused speech, and was able to localize pain. His pupils were equal and reactive to light. He did not have any obvious focal neurological deficits at that time. And CVS, the most remarkable thing was slightly elevated blood pressure at 150/93. Respiratory exam at the time of leaving the facility, notably, he had a mild tachypnea and had a borderline oxygen saturation of 94% at room air. Referral processes that occurred for this particular patient. The hospital that was receiving did not get any pre-notification for this patient. We noted that there was no pre-referral preparation and stabilization for the patient. The caretaker has consented to referral, obviously, like any other patient who is deteriorating, but it was verbal. They came in a type A ambulance, and the transport team, like I had earlier highlighted, involved two nursing students who are in year one and an ambulance driver. We did not receive any communication, like I earlier highlighted. This referral, we noted that there was no coordination between the referral and the receiving facilities. The decision to refer the patient was right because they wanted the patient to have a brain CT scan, and the facility did not have capacity to do a brain CT scan. So the patient was referred for brain CT scan and further management. So the decision was appropriate. ENROT, the team that brought the patient noted that there was no care given ENROT. However, when they were about to arrive Mulago, about 10 minutes, they noticed that the patient was concerningly reducing in levels of consciousness. So that they took vitals again, and they noted that the blood pressure was 140/95, the pulse rate was 82, the oxygen saturation was 89 on room air, and at that point, they decided to initiate oxygen therapy using nasal pumps with 5 liters. When they reached Malago, since their destination was to go for a brain CT scan, they went ahead to do a brain CT scan, but however, the patient was taken while off oxygen. And then later on, brought to medical emergency, still not on oxygen. The image that was showed earlier is the brain CT scan that was done, and we noted there was nothing significant observed on this brain image. I know there is a light background, it could interrupt, but it was a non-significant brain CT scan. It was non-contrasted. So upon arrival at the ED, we quickly did a primary survey on the patient, and we noted that the area was at risk due to the reduced levels of consciousness. Respiratory rate was about 20 beats per minute. We had good chest movement and expansion, good air entry with normal breath sounds. The oxygen was 90% on room air. We had warm peripheries. Our peripheral time was normal. Our pulse rate was 80. Sorry, there's a mistake, but it was about 80 beats per minute. And then the blood pressure was 148/90. Heart sounds 1 and 2 were normal. We noted that the GCS was lower than what had been written in the pre-referral notification. So it was 8 out of 15 at this point. And we did not note any obvious focal neurological deficits. We did not observe any seizures. When we took the random sugar of this patient, we found it to be at 1.8 millimoles per liter. On exposure, patient was febrile to touch, and there was no any other finding that we noted that was significant to report. So immediately from the primary survey, we raised the head of bed because we found our air to be at risk. We did not find need to insert an oropharyngeal at this point because the patient still had a good gag reflex. We initiated oxygen therapy at 3 liters, and the SpO2 improved to 95. We gave dextrose 50%, 25 grams, and then patient woke up, returned to full conscious state, and then later on, about 10 minutes in, we maintained on D10 as we were reassessing the patient. We also gave a fluid bolus of 500 mils since the patient reportedly had not been feeding. We reviewed the regimen of the patient. He had been on metformin 1 gram BD and glibenclamide. So immediately we advised the patient not to use the glibenclamide for startups, and then we took the labs off for a full workup. And then to focus our discussion on the referral process, we shall not go into details that occurred later on, the sample and then the secondary survey and then follow-up care within the hospital. However, just to put into context, this patient was well and was discharged back home within 24 hours. So the lessons we learned from this referral is that 1, our patient lacked a comprehensive pre-referral assessment, and notably for a patient who was a non-DM and already on treatment, we thought that the referral site could have at least taken note of the pre-referral random blood sugar for the patient. And then we also noticed that there were gaps in communication that I know are still existing, but I think that's why this presentation is here, so that we can highlight and find a way to help each other. We also learned that critically ill patients require to be transported by teams that have done appropriate training, at least in basic emergency care or some sort of training in emergency care to be able to transport. For a patient that the team flagged to have a GCS of 10, we thought that they should have chosen someone more skilled to transport this patient rather than just nursing students who are at the start of their journey in care, in medical school. And then we also noticed that the team did not do a good continuous monitoring en route, and then they think they kept doubting their decisions on care of these patients. We also did not have documentation for the patient en route, which we thought was a gap that should be addressed or should be discussed in this meeting. So we recommend from this presentation that yes, we're going to talk about it, but I know some of these things could be there, but re-emphasizing them, standardized referral and transfer protocols. And these should include what should be done at the referral site, and then how can we structurally hand over these patients to the receiving facilities. And then we ensure we have free referral communication so that we assess the state of the facilities that are going to receive our patients. Ensure that, yes, this is a very specific point for patients with altered mental states. We always say, do not forget their random blood sugar. And then we hope that from this training, we shall be able to find a way forward that we get trained personnel or ensure that ambulances do have trained personnel, essential monitoring equipment, and emergency supplies. And then we should also think of introducing referral checklists so that in case the team forgets, they're able to check that for every patient that is leaving their facility, have they done maybe a primary survey? Have we put this? Have we put this in the ambulance? So that we enable the teams that are transferring these patients to be able to adequately check, stabilize, and also safely transfer these patients. And then lastly, we should provide regular training and mentorship and keep reminding our teams that transfer patients, mostly for critically ill patients. Yeah, because it's not just about transport, it's about continuity of care, even in not. Yeah, thank you. That was our brief presentation and for this case. Thank you.
Wow. Thank you so much, Dr. Anna, for that wonderful scenario. Yeah, you're receiving a lot of thumbs up from the rest of the country and the world, I would say, because a lot of people are actually online from different countries, which I'll mention as we move along. There is a lot to learn from this scenario, and the way people are responding to you indicates to us that I think it's pertinent to each one of us, both or most especially in pre-hospital, how do we, even from the facility, how do we refer patients, but also how do we move them? What is the communication in between? Wonderful. But the recommendation is what I liked most, where you said provide not only training, but also training and retraining. Thank you so much, Anna. Maybe at this point, I should welcome any questions or clarifications to this scenario we've just had. Members, those who would wish to ask Anna any questions or any additions or any clarification on the case, because it is just opened our door for the discussion, yet we have so much to come. So if you have any concerns, any questions specifically to this particular scenario, please raise up your hand. We'll be able to pick you up. I've not seen any hands up. Okay, I think out of the almost 300 participants, we've not had any person who would wish to say anything at this point. Maybe later on. We'll give you another chance. We'll give you another chance later on to ask All right. I would like to call upon another presenter. As I said, we have an obs and gyne expert in our midst as one of the panelists, and I would give him a chance at this moment to share experience on the referral systems in as far as obs and gyne is concerned, especially in the Mbale region. So Dr. Peter, kindly speak to us.
Yes, thank you, moderator, for this session and members who are present online. So as I already told you, my name is Dr. Peter Wanyera. I'm an obs and gyne in Mbale Regional Referral Hospital, and also currently I coordinate Uganda local maternity and neonatal system. And I'm glad to be here with you, that we'll be able to have some sharing about the elements perspective of using a coordinated referral system to be able to improve the maternal and neonatal outcomes. And we have been able to see this happen in the Uganda region. So we shall have a brief talk about what the introduction is, good practices of obstetric referral, elements interventions in the referral process, and what are the results which have come out of that coordinated obs and gyne referral. So importantly, a referral, we define it as a process in which a health work at one level of a health system, having insufficient resources in terms of drugs, equipment, or skill, so many other things to manage a clinical condition, seeks assistance of a better or different resourced facility at the same level or at a higher level to assist taking. Sorry. Yes. Yeah, but
yeah, but the game say that then it just
Next one, small. Yeah, okay.
Yeah, it's just a small technical glitch, but we've received quite a number of comments from the previous presentation from Dr. Kaguna. There are quite a lot, and I am happy that Dr. Marion is ably responding to most of them. So, dear participants, we are back to Dr. Peter right now.
Yes. So thank you. Sorry about that. I think there was a technical issue and we were unable to see the slides. I was just on the first slide of finding a referral, and I was saying that normally it is a referral process which normally involves moving a client from one source to another, which could be having challenges in terms of drugs, equipment, or the skills of the health worker to manage that patient at that time and seek access of a better resourced facility, which could be at the same level or a higher level facility to assist in taking over the management of that client. And for us, it's somebody pregnant women. And we emphasize that referral is part of management of our patients' obstetrics. If it is well coordinated, we are able to see results like in our region. So, good obstetric referral practices, number one is we emphasize that the referral should be made timely and should be initiated not when it is too late. It should be made on time when we detect that there is a problem and we initiate a referral for this mother. At the end, you're able to have good outcomes for the mother and the baby. Should be well communicated with the referral site, and the referral form should be well documented by qualified health worker. So this communication is very important, that it is able to prepare the site, is able to receive this mother, and be able to even alert the referring site that please, the services are available. Sometimes we have had, because of the communication, we have had these cases arrive like for blood transfusion, rare blood groups like rhesus negative blood group. As the mother arrives, the blood also has been donated from whatever it is from the bank, and there is no delay in giving the service. That's the power of communication. It's recommended that actually we are supposed to accompany this mother by skilled health worker if it's available. But when there's limited human resources, we are saying referral communication is not optional and it's giving us very good results in most cases. So it should be received as a referral site with the available services required. So we refer patients to places where we know that these services are available, and then we waste a lot of time moving this mother from one facility to another. And at the end, we are able to have bad outcomes. So we refer on the target, we are sure that the service is available. And the referring site should be able to get a feedback from the facility which has received this client, and they give them a feedback of what were the outcomes of their referral and possibly what are some of the things which need to be improved or to be able to be done better. So the practice continue. We anticipate that way these patients are being transported in obstetrics and gynecology. We have referring means, appropriate means, and we recommend these mothers should be moved in motor vehicles. We have ambulance systems which are well coordinated in Elgon region and the headquarters in Bari Regional Referral Hospital. So we have an ambulance coordinator who is in charge of the whole region. At any one time, when he's called, is able to respond and dispatch an ambulance at an appropriate time and be able to give a location where this ambulance is. And occasionally, we have what we have called modernized tuk-tuk or tricycles. And these are given by partners. Because of the terrain of Elgon region, there are some places where the ambulance vehicle might not be able to reach, but the tricycle can be able to maneuver with this patient and are able to move this patient when there's an emergency. As the motor vehicle ambulance comes, the tuk-tuk leaves with this patient or the tricycle along the way, because you'll be able to see, like the ones you're seeing there, it has even oxygen. That tuk-tuk you see was donated by Rotary, and it has even oxygen cylinder inside there. They can even administer oxygen. So in order not to waste time because of the terrain or the location, because some facilities are very far, it starts the journey and they meet along the way and they fasten the process of transporting these mothers, and good outcomes are being registered in a good number of facilities. So what has the local maternity and the NATO system interventions been able to harvest from this and been able to do? Number one, we, as a local maternity, we are working on modalities that we track all referrals to be able to identify what are the common reasons for referral, which are the common referring sites. And through this, we provide feedback to the respective sites and are able to internalize this information in terms of their outcome, because of being able to track if a certain facility refers more, why is it referring? Sometimes issues of human resource, lack of equipment and whatever, and along the way, we have been able to have items which have been required, like anesthesia machines, operating beds, because of being able to track the referrals. And we have had some places where they refer because no anesthetist, there is no doctor, and there has been recruitment because of feedback as early awareness through tracking the referrals and being able to have some human resource midwives, doctors, anesthesia providers recruited by district local government, and have improved the quality of care timely for our mothers. So through Elgon region, we are advocating for what we call fuel pooling, whereby health facilities come together and they are able to, in a quarterly way, be able to contribute some funds from the government funds they receive to be able to put it in a pool to support fuel availability for the running of ambulances for Russian, so that the mothers do not have to go into their pockets to look for ways of being transported. So this is one of the things, and good number of districts have brought this to the DHOs, and it's almost becoming something very easy for the mothers to move from one place to another. So we have an ambulance coordinating person who is in Elgon region, and through the Lemons platform, we have shared these contacts, and members are able to access things 24/7 and is able to be reached out and can be able to help sort out some of the things concerning the referrals of mothers from one facility to another. So through the tuk-tuks and the tricycles, which are provided by the IPs, This one, some of them are closer to some smoke sites in small flat surfaces. As they wait for ambulance, sometimes they can move very fast to be able to deliver. We have some facilities which are as closer as 1 kilometer, 2 kilometers away from the referral site. Sometimes they easily move these people. As the ambulance comes, sometimes the work is already done. And some of them, as I said, they have oxygen and are really doing the great work. So you can be able to see that is the beauty of some of our previously. That's for one of the facility. The topmost picture you see, they had a tricycle, which was in having, you see, it is shared, it has everything, and one of the IPs came on board and was able to get them. This one, which has even a siren with a yellow light on top, the ambulance seat has even a writing of ambulance, that one. Then when you go to the downer picture on the right, you see at the end that there is an oxygen cylinder inside there, well stocked with oxygen, and they keep refilling. So even if the mother has fetal distress, the mother moves in that for a shorter distance, but on oxygen, and has improved the outcomes of our mothers. We have also discussion topics about good referral process. In our Tuesday early morning virtual discussions from 7:30, we have allocated this, and we brainstorm and be able to discuss how has the referral process been for the previous quarter, and we'll be able to share, people share the standards of what it is, and we are putting on our norms that this is how our obstetrics and the gynecological referral should be. And with the attendance of so many people, we're able to get so many learnings, and we'll be able to implement things locally using our local solutions. And we are growing the standards of care, not diverting from the national standards which do exist. So in some circumstances, through this good coordination of communication and other things, we have had some circumstances, the specialists being moved by the ambulance. When a health center for maybe there is a difficult case ongoing in the theater, maybe a cesarean section, when they call for the ambulance, if the specialists are available, sometimes moves in this ambulance and goes and sorts out this mother at the health center for in a theater. And this reduces the time wasted, and the mother is not moved from one facility to another because of maybe challenges in terms of skill and so many other things. So this has been one of the achievements we've been able to do. Then we do our inter-elements collaboration with the neighboring elements, analyzing the trend of referrals, and we've been able to identify that so many of the referrals, even if they belong to other elements, can be able to be combated through efforts being put together, and being able to rectify, provide equipment, the neighboring elements, be able to provide blood products, and we are able to save so many mothers. So as Elgon region, we have agreed that all MNCH providing sites should have a phone for communication before referral, or sometimes it is used for consultation to improve the quality of care of our mothers. So referrals we have agreed to be made to the nearest smoke facility. Previously, we have had that a referral, once the mother is to be referred, means the regional referral hospital. We have demystified that when you are making a referral, you refer to the nearest smoke facility to you, in the case you have a BMOCO facility. And that is one of the standards. When it's unable to manage, that's when it sends to the next level. But with the communication, teams should be able to accept that truly we are able to handle this case, and they should be able to take on. Then horizontal referral is also recommended among SMOCO sites. You can have a health center for the neighboring health center can refer there in case they have any challenge in offering a service. But if the regional referral hospital is near, they can be able to send it. And this is working very well. That a regional referral hospital refers to the neighboring regional referral hospital, and also the general hospitals which are there refer to the general hospitals. I mean, then the health center do not refer to their fellow health center. For them, if they are unable to handle, they refer to the next facility, which is basically the health center for. But we have agreed on this horizontal referral of mothers, which is working very well. that were found somewhere in the center force are neighboring each other because of some few hiccups. One may not be proof of service, and the rest, the neighboring should be able to provide. So we have a WhatsApp platform for all the MNCH providers in the Elgon region, where we discuss part of our things in terms of quality of care of our mothers, the standards of how a referral was made, and we've been able to critique some of the referral forms generated by some of our colleagues and be able to give input, and it has improved the quality of care and the way how a referral should be made, and it is yielding good results. So what are some of the results we've been able to harness out of this good coordination? We have been able to transfer blood from the regional blood bank to a peripheral facility, and also at times when a mother, the reason for referrals for blood transfusion is better we are transporting blood from the regional blood bank to the mother, other than transporting a mother from a peripheral facility, a river site, to the regional or referral hospital for blood transfusion. And we have seen that you find a mother in a stable state of oxygen compared to putting her on potholes on the road. Transport yet she's very weak, and the problem is on the blood. And this is working out very well for us. So through this, we have had some facilities be able to access equipment through purchase. We have been able to reallocate anesthesia machine, blood fridges from one place to another, and this has improved the quality of care of our mothers. Through tracking of our referrals, we have been able to identify that some CMOCO facilities were non-functional. No doctor, no equipment, and all other things, and we've been able to come on a round table with the leaders, the technical teams, and we've been able to functionalize some of the health centers. And currently we're at almost 100% functionality through coordinating our referrals and be able to understand why in this small facility is by paper being able to refer these mothers, and some of the things have been able to be closed and functionalizing satellite neonatal care units in terms of our babies. So importantly, we have sufficient number of human resources who have been able to be recruited through our referral processes, tracking, and we talk to the members about the quality of the outcomes of the referral, which we feel if it was handled because of limitations, the outcomes would have been better. And we have so many people who have been brought on board because of our feedback from referral processes. So CMOCO facilities are more operational now, 24/7, because we are tracking referrals when they arrive from where we shall be able to know what is the problem in this CMOCO facility. And together, there are sometimes there are genuine problems. We work with the technical leadership, the DHOs, the CAOs, and all other political leaders, and have been able to get solutions to improve the quality of care of our mothers. So the impact that last we are having a reduced congestion at the regional referral hospital and other CMOCO sites, because all the places people are up to their arms doing their work, and hence we have not only a reduction in maternal and perinatal mortality in the region and even at the regional referral hospital compared to the other years as it has been. So that is a trend of referrals before tracking and taking the emergency intervention that you can be able to see for the last 4 years, the financial years. There was a new year whereby that facility received less than 2,500 referrals. But after implementing the LMNS model, we have been able for the last financial 2024-2025 register less than 2,000 referrals in 12 months, which had never happened for so many years. And the ideas keep progressing. It is going to be much and much better through this. So the days of out of stock and the number of essential commodities reduced in that institution, that's the regional referral hospital, and less staff burnout because the other peripheral sites are doing their work as expected. So that's a trend of maternal deaths for the year 2024-2025, and you can be able to see that the first 2 quarters were really bad, and solutions were sought for to be able to see why are these deaths very high. And one of the things were what we call inappropriate referrals, not unnecessary, inappropriate referrals. And we're able to find a solution for them, and as you're able to see, the graphs changed massively. We're all quarter registering for maternal deaths, and you can see in terms the orange color shows maternal deaths which are referrals in, and you can be able to see that for the quarter which registered the 4, all of them came in and majority, and they died within 24 hours and come up with a remedy, and we are doing much better. This year when it ends, the graphs are going to be very different. So one of the things that the communication mechanism, we have not put it as something optional, and with the support of Seed Global Health was able to support Mbale Regional Referral Hospital with those phones. And at any one time, you can access the labor suite of Mbale Regional Referral Hospital 24/7. They are mounted there, not mobile. They are rechargeable there. At any one time, you can call in and you will be able to be received and you explain your problem and the mother comes. And this is a standard. We are doing that all facilities delivering our mother must have a phone for communication, whatever model it is, provided there must be communication mechanism. And we are seeing the results out of this communication. So we have agreed that when you have these emergency lines, you should distribute to your catchment area for the people to be able to know them and be able to utilize. And that's a sample from Mbale Regional Referral Hospital that this is known in 16 districts and 1 city. Whoever touches a mother in that catchment area of the 16 districts and 1 city and Mbale Regional Referral Hospital, they know these numbers and the calls are quite massive. Some of them consultation, others truly planning to refer, and the results are very amazing. Thank you so much.
Wow. I cannot hear how you're clapping, but I can imagine that each one of us is clapping in their own way for this wonderful presentation that that Dr. Peter has given us. Ladies and gentlemen on the call, this is not the whole of Uganda. I must say this. This is just Elgon region. For the team out there, managers of institutions out there, what are you doing in your region? You can answer me that later on, but I would ask if there is any question from the members. Okay, we already have hands up. I think people are already thinking, already having burning questions to give to us. Clapping and appreciating. Okay, but there are a lot of comments that have come through, and Dr. Marion, I think, is doing a wonderful job. Can private facilities refer to government facilities? Dr. Marion, I think, is handling that. Thank you, Doctor, for sharing. Okay, most of us just thanking you for the wonderful presentation. Doctor, what happens to facilities that do not have, that do RBS? I think that was referring to something else. Okay, maybe we can give him a chance to answer that particular question.
Okay, good. Thank you, the members outside there, and I've been able to see someone asked that can a private facility refer to a government facility? The answer is yes, because we are all serving the same population, but this member by choice decided to go the other side. So in case that private facility does not have the potential to continue with the care of this patient, they are mandated to refer to a higher facility, the government ones which exist. It's acceptable. So a BIMOCO facility that is from health center 3s and below, health center 3s, 2s, that are classified as BIMOCO, that's basic emergency obstetric and neonatal care. They do the basics. So when we talk of CIMOCO, that is health center 4 and above. So of all the things they do at the health center 3s and 2s, antenatal and everything, So the health center force go ahead to do the blood transfusion and cesarean section from health center for another, and that differentiates them from the health center there is and two. So currently the health center there is in Uganda do not do cesarean sections and they do not offer blood transfusion. So any patient requires that service only available minimum in a health center for status in Uganda, apart from some PNLP facilities. Thank you very much.
Yeah, Peter has a question here. Now, what challenges are associated with using tukutuku? Thinking that everything is not a bed of roses, maybe there might be some challenges that are associated that you wish to know. Then Lillian Balunji says, my worry is reducing or limiting ambulance access to non-MCH clients.
For permission.
Okay, Lillian, we'll get back to you. Maybe the last one is, I'm from the Renzori region, but it's difficult to get phone numbers of the regional referral hospital. So communication becomes difficult prior to referral. Okay, I think it's just a comment, not. Can we also get somebody who had their hands up? Okay, Sylvia. Yes, my Sylvia, Natukunda from Barara. Please unmute and talk to us.
Thank you so much, our leaders, for this echo. It's an exciting one, by the way. We are happy to see you all on the call. Our commissioner, you are welcome to the echo. We've been missing your presence. And our president plus Dr. Marion. We thank you all, and we thank you, the representative from Bare session. My question to you is, I see you are doing a great work, BGY. On your chart where you displayed the call numbers for emergencies, you mentioned lab, you mentioned PID, you mentioned OBGY, but you didn't mention A and E. And now, if you've cascaded this chart, everyone, it would be right to include the emergency department's number, because not everyone will come while pregnant or is a baby. There are people who have accidents. So would like to see another emergency number for emergency ward department, because I've seen you are doing well in OBGY. It will be the same thing to do that. Thank you. Maybe before I also go, I had another point for our case presentation. We are finding like patients are getting more deteriorated because we miss. So in our referral system, it's good to always take a blood sugar check, because we've loaded patients in ambulance. Just start the vitals, you check around the ABCD, you check the glucose level, you find the patient is at 1.9. You already pick the patient from ward, so we find it's also a reason why our patients deteriorate and feel they are being referred while missing up a small thing. Otherwise, I thank you so much. Enjoy the call. Thank you.
Yeah, thank you so much, Sylvia. We have another hand from Hisa. Hisa, please unmute yourself and speak to us.
Yeah, thank you so much, Mr. President. It's nice to meet you again on the call. I would like to extend my sincere appreciation for the attendance of our commissioner and Dr. Marion, plus my LMS coordinator, Dr. Wanyera Peter. I must thank you so much for the work you're doing in Mbale. It's really, really tremendous. I'm Hissa from Busole General Hospital, and I'm the ambulance folk person. Dr. Peter has really guided us quite so many times, and we really appreciate his services. However, just maybe to say something on Sylvia's comment, they also have a contact for accidents and emergency that were shared in the group. And we quite communicate oftenly when we have a referral for clear coordination. I have a question that I will need some guidance from the experts. Sometimes we get calls from private facilities to respond. Maybe it's an obstetric case, and we get hiccups on the issue of what? Fuel, because this is a private patient who went to private facility, and then our bosses may be like, but this patient can afford fuel. Can they really help us and we save our fuel for these vulnerable patients that we may have? So sometimes we have that debate, and sometimes it consumes time when you're in the process of responding. So I would love our bosses to respond on this, to guide us, even if it's a private patient. Can we clearly go and respond to that private facility using the fuel that we have? Thank you so much.
Thank you so much, Hissa, for your concerns, and I'm happy that over coming to 400 participants on the call. Unfortunately, we cannot get everybody, but in the event that you wish to say something, kindly put it in the chat. We have our experts there who can ably respond to you. Yeah, Dr. Peter, maybe you get answers for those concerns.
Okay.
Precious.
Thank you. One of the members asked that not everything are like flowers, which are in some of the places. So one of the things we have with it is that the speed at which it moves is not equivalent to a motor vehicle. So if it is distant, normally if there are any challenges with road network or whatever, sometimes they might take some time to arrive. But we have ambulances which are spread all over the region. And as I said, that in these tricycles, some of them, since they are small, they're able to maneuver some roads and be able to pick some of these clients. And because of the terrain, they are able to meet with the ambulances in an accessible part. They hand over the patient and they go back, and the ambulance continues, a motor vehicle continues the patient in a faster way and can be able to reach the hospital at a faster rate. Then somebody said that limiting the ambulance to non-MCH beneficiaries. I think the ambulances are for all people of Uganda, of that region. And in terms of this presentation, the focus was in terms of obstetrics and gynecological benefits of the referral system. And what I know, the ambulance have been able to see them reach accident scenes, Red Cross ambulances, Ministry of Health ambulance, and are able to retrieve these people. So, but I think maybe she might have done an analysis and seen that mothers are using more of these vehicles compared to other categories of people. But what I know, they are for all Ugandans. Commissioner will be able to say something that, but I've been able to see it in Elgon region. They carry all people. Then the accident and emergency contact. Currently, the ambulance coordinator, in case there is an accident, for our region, on our platform, we have shared his number there. He sends ambulance to all the areas. Currently, we do not have in our hospital specifically a telephone number that once there is an emergency calling, those numbers I displayed there, they are for wards specifically, that specific emergency obstetrics and gynecological area, which handles obstetrics and gynae emergencies. So, but in terms of the contacts, the ambulance coordinator of the region, who is very active, is able to respond and has done very good work. The fuel for private patients, should we use the same fuel to go and pick the private patients? That looks to be a challenge. A commissioner will be able to guide, but as Elgonere Mwenes, we have agreed that this mode of pooling of fuel, even private facilities and PNFPs in that district, provided hand mothers and babies, we have agreed you should contribute to that pool at any one time, it is so that you are able to be responded to at any one time, even in all government facilities. So we think it is acceptable to be picked because these are the same patients only that are located in different areas. Unless if there are other things, but the Commissioner in his presentation, I know you'll be able to guide more about that. And thank you very much.
Yeah, thank you so much. Participants logged in from across Africa, South Africa, and Kenya and Rwanda. You're all welcome to this eco session. It is the 115th eco session of the 8th sitting in 2026. So you're all welcome. And what we're discussing today is none other than the referral processes. And there are key things from the previous presenters that are coming out loudly. Commissioner will talk about this, but there's something that has caught my eye or my attention. It's about the pooling of resources. Here we struggle a lot, and Commissioner, one time I heard it from Busoga region where they are trying also the pooling of fuel from facilities, and it seemed to work that time when I went there. It is something that maybe we have to think about, but also as we call in our last presenter, who is the Commissioner, maybe will also guide us on if from the current budget, we have seen that Ministry of Health has been allocated 5.2 trillion shillings. Maybe we should have also, and part of that goes to emergency response. Maybe that's where we should also have something for 2026, 2027. Ladies and gentlemen, allow me to call in Commissioner Emergency Medical Services to speak to us and also guide us in the same forum. Commissioner, you're welcome.
Thank you, our President Tom, and thank you, Dr. Peter, for that great submission, and previously also appreciate Dr. Kaguna. The first two presenters have given us the practical experience of what is taking place in the referral system. I'm now going to give you what I may describe as standards for the referral system. And as I speak to you, the referral system, we started realizing it as a key area in 2017, 2018. And in 2018, the Ministry of Health developed what we call referral guidelines. And we have been following that. Before I start on, I want to comment that there has been a big debate on the tukutuku. And so when I presented the issue of their effectiveness in the Committee of Parliamentarians for the Health, they were concerned that they are not ambulances to carry the women, and particularly the women MPs were not amused. But Dr. Peter has shared some of the experiences we have in Mbale, and we started that process, I think way back in 2011 or 2012. That time I was working also in the Elgon region. So there is a practice, and he has explained it very well. And the issue which someone commented on the utilization of ambulances by obstetrics, limiting out to others, we know that up to 66% of our ambulance utilization is by emergency obstetric and neonatal cases. That is because of what currently the society takes. Then the last comment on the pooling, I'm happy to receive that report that Elgon is doing a good job at pooling. It is the way to go. And lastly, what the president commented on the budget, which was read yesterday, we want to appreciate the government of Uganda, especially His Excellency the President and the Finance Minister. We received additional funds for the emergency medical services, and this is good. This is almost, I think it's doubling our budget. I think we received 10 billion for fuel for the next financial year. And we have received, I think, something like 20 billion for new ambulances. So that's a good step, but still takes us a small percentage. Okay, back to the presentation. Members, Dr. Peter talked about the referral system, and I want to tell you that we call it a system because we require many things in order for us to make referral work. And some of you, if you use the WHO definition of what a health system is, it has 6 blocks, which means it must have management, it should have logistics, it should have human resource, it should have information systems, and should have the actual service delivery, and should be financed. So that's why this referral is not just a small thing. It is a whole system which we must look at. Go ahead. Okay, we shall look at those areas: introduction, then the strategic alignment of referral in our system, types of referral, our referral levels in Uganda, the pathways, protocols, which Dr. Kaguna and Dr. Peter have already passed through, the call and dispatch system, and what I think should be our next focus. Referral system, again, Dr. Peter brought it out, that this is the organizational structure for coordinating, linking, and transferring responsibilities of care from one level to the other. It could be at health facility level, which Dr. Peter was explaining here, maybe from health center 2 to 3. It could be for health provider, like from a general practitioner to a specialist. It could be from one specialist to another specialist. It could be from one hospital to another hospital. And it is a process of directing a client to another source of service, assistance, or information. Now, what is emergency referral? Emergency referral, comes in the case when there is a threat to life, either threaten life, limb, or pose serious risk to health. Another way of looking at an emergency referral is for conditions that may not threaten life, limb, or eyesight, but require urgent attention to prevent them from becoming a serious risk to health. And one example is what Dr. Peter was presenting. When you refer an obstetric mother whom you have identified to be a risky mother, she may not be in an emergency at that time, but you are referring her as an emergency because you want to prevent her from becoming an emergency at a near point. Then the routine referral is a referral process due to seek a second opinion at a higher level or an investigation. The referral system has now been streamlined within our strategic documents. And the first biggest document is the National Development Plan 4. The Cabinet of Uganda in Strategic Directive 757 has committed the country to develop the National Ambulance Service, the emergency care system, and the referral system. So we have a recognition at that high level. And when you look at the PIAP, it details out what we are supposed to do. The Ministry of Health strategic plan for the next period, 2025-26 to 2029-2030, you will check page 82. We spell out issues about emergency care and referral system. Also, the ministerial policy statement of 2026-27 details out that. Then the emergency medical services policy and the implementation plan 2021. That is the alignment which shows that we are focusing the referral system to improve. Why do we refer? Because we need to provide comprehensive care in places where the technical skills and the resources are available for the type of patient you are seeing. The other reason is to help people receive specialized services which are available at a higher level. Like if you are working at a lower level, you're at a health center 4, and you realize this patient will benefit from being at a hospital where there's a specialist, you refer for that purpose. Also want to make appropriate use of infrastructure, health infrastructure at the level where it is. And Dr. Peter was giving us an example saying that now more people are managed at a health center 4, and it has reduced the use of the health of the regional referral. This means they are making use of bullet 3 there, where the infrastructure we have at Health Center 4 is well used. Then a specialist at the regional hospital has time to look at only the cases which are due for him. Continue. Now, these referrals are classified. We have the traditional system. We classify them into external, which has horizontal and vertical, into internal, and then international. We have the modern system, which is ICSS, and we have other forms of referral, which are interdisciplinary or interdisciplinary. I'll detail down in other slides. In terms of external, we look at vertical referral, where you refer from a lower level to a higher level, and vice versa. You look at horizontal. Again, Dr. Peter was explaining to you this. Patient referral from one facility to the other facility of the same level. Like he gave you the example 4 to 4. But you can be able to refer, you are at the same level, but you may differ. And sometimes we are seeing some referrals which are not okay. Someone says the doctor was absent. So it refers to the next level, but that is really horizontal, because one health center for one staff was absent and they decided to send to another health center for. Now, international referrals, there is a special guide which is on international referrals, and Uganda, we have developed that system effectively. We shall not go so much into that. Most of ours is going to be on what we are doing within the country. In terms of modern referral systems, there is what we call interval referral. Interval referral means a patient is referred to complete care for a limited period. You just send this patient to a colleague to do something, but he sends back that patient. That is called interval referral. Then collateral referral means that the referring medical doctor retains the overall responsibility, but he refers the patient for care of some specific problems. Now, this I'll give you an example, like you are running a clinic, but maybe you don't have a CT scan. You just send it out for a short time for a CT scan, but it is you who is responsible for everything to do with that patient. Then there is what we call split referral. the responsibility for caring for this patient is divided between 2 or more doctors. It can be 2 specialists. Like a patient is a pregnant mother, but also has a psychotic problem. So both of you, the obstetrician and the psychiatrist are taking care of that patient at the same time. We call that split referral. Then self-referral, it is common nowadays where a patient becomes dissatisfied with you and says, "Doctor, I think allow me go to the next level." It is not your initiative, it is the patient who has done so. Others may not even ask, they will just walk. And when they reach a referral site, they say, "I was attended to by Dr. JB, now I've come to you." You ask, "Did he refer?" You find that the patient decided himself. Continue. Then there is this class which we call other types. Intradisciplinary referral. When a patient cannot be treated, neither properly diagnosed nor satisfied with a particular treatment or therapy, then he can be referred to another therapy of the same discipline for the needful. A patient, it could be a patient you are providing, like this is common in patients like those of physiotherapy. You are providing the same service. Now the patient doesn't feel you are, so you just decide that you probably let me send you to another person. It's going to do the same thing, but it becomes more satisfying to the patient because there are other things which go with patient satisfaction. Then interdisciplinary referrals, the patient shifts from one system to another. It can be able to move from the one caring area to another. Continue. Now, in referral, I've already commented on this. Vertical is from lower to higher. Horizontal, similar levels. Now there is another one called diagonal. Referrals can also be diagonal. Diagonal refers to when a lower level of health facility directly refers to a tertiary. You cross so many levels to a tertiary. And this is, sometimes it may be abused, sometimes it may be necessary. I'll explain in front there. Now, these are our levels of referral facilities. I try to get, this is from the 2024-2025 Ministry of Health status report, but I'll concentrate more on government. As you see from down, begin from down at clinic level, clinics are mainly in the private sector. Now we go up to health center 2 is the first, followed by health center 3, then health center 4, general hospital, regional referral hospital, national referral hospital, and SH is specialized hospital. So you move. If you began from health center 2, you'd see that numbers are more down in a public than up as you go. Continue. Now, there are 3 levels of classification in terms of referral. We have what we call primary facilities for referral. Primary facilities for referral include community health systems. They choose VHTs, health center 2s, and health center 3. Those are primary levels in our setting. Then the secondary levels are health center 4 and general hospital. Then the tertiary ones are those 3: regional referral hospitals, national referral hospitals, and specialized referral hospitals. Now at the community level, the VHTs cover about 1,000 people. VHT is village health teams. Then they choose at parish level of about 5,000 people. They provide mainly preventive and promotive health services. Now, the president was talking about COVID. Now they do also community-based surveillance. They are the ones who can tell us that many people have died in a certain community, and then that becomes an alert for us. They also refer And now they are being trained shortly, especially they choose to provide some treatment for common ailments. Then the health center too, basically it's at parish level. This has been now discouraged in the current system. It used to be that every parish should have a health center too, but we are now building more of a health center there, as you will see. It provides preventive, promotive, outpatient, curative, and if a mother comes and really cannot be sent to health center 3, may be delivered at a health center 2. But the provision of a health center 2 is not for delivering mothers. Now, I think I thought I had missed out the health center 3. Now, this serves a population of about 20,000 people. This is the first fully functional unit of the health system. It has 14 beds and it has the standard infrastructure. Revisions are being made, and also it provides for the structure has been reviewed. I think I will check that, but it provides now for about 50 staff, but it includes a doctor. That is what I wanted to tell you, that the current health center 3 structure includes a medical doctor. The services they provide is preventive, promotive, OPD, curative, maternity, inpatient, and laboratory. Now in maternity, which Peter was passing you through, this is where officially we are supposed to have our deliveries. But in hard to reach areas, health center 2s are doing deliveries. Now health center 4, this is the first referral level. When I was starting service, this was my first place of work. It covers a population of 100,000 and 24 beds. In the new structure, we are moving them to community hospitals, and there will be 8 beds. The human resource includes doctors, and now it also includes pharmacists, and the number has been increased to about 108. It provides all services at Health Center 3. It is now doing investigations, does emergency resilience sections, which Dr. Peter was telling you it is CMOC. It does life-saving surgical operations, blood transfusion, and mortuary. Now, the general hospital, currently, it covers a population of 500,000. Beds can go up to 250, and it has all the major specialties. It is on top of a health center 4, it does most of the major, the general surgical and medical conditions. They are also providing for specialist services. This has not taken a root, for the exception of a few general hospitals like Uganda, Mityana, a few of them, and Kiriandongo. The regional referral hospital, this is one of the biggest centers, and Dr. Peter works in Mbale Regional, which covers a population of 4.6 million, not 2 million. So that area, we are planning to have a second referral hospital because the standard is 2 million people. Beds are like 500. Now the human resource is 1208, including various specialists, and it has huge infrastructure, and the services I've outlined for you some of those services. What is key there is that it includes the regional medical dispatch system, which all of you have got to understand. That is the coordination center for the pre-hospital system. The national referral covers population of about 10 million. They are usually defined according to that hierarchy, while the specialized hospitals do not have a defined catchment population. The services outlined there, and you will see that there are those which may not exist at lower level. Neurology, endocrinology, metabolic disease, gastroenterology, and so on. Nuclear medicine, neurosurgery, cardiovascular. All of these are advanced services offered at the referral hospital. And that is the reason why the referral system in Uganda is hierarchical. Now, these specialized hospitals, the population is not very important. And I wanted to spread it out for you, some examples of those, like Uganda Heart Institute. It's mainly dealing with cardiac care. Uganda Cancer Institute with cancer therapy, Women Neonatal Hospital, Emergency Surgery Hospital in Entebbe is mainly pediatric. Chua Hospital in Mbale is mainly neurosurgical. So those are specialized referral hospitals. They don't define a certain population, but their population is disease-based. And most of them are situated here in Kampala, but the thinking is that we must have them also across the main regions. Now I'll go on to the referral pathways. Now, referral pathway, the way you hear the word pathway is a route. How do patients move through this system? How do they reach one area to the other? We do not have that very well prescribed in writing, but we know that a patient must move from a community health worker to a health center from there to a health center 3, from there to a 4, like that. That's how, but we don't have it. Now, in standard, a referral pathway should be a local arrangement on best practice where doctors, specialists, nurses alike design a patient pathway and a treatment plan. And these are written down so that people are taught during these CMEs and everyone knows that, so that when you are referring your patient, you don't refer in abstract. You can be able to even describe how the patient should move through the system. Continue. Now, I bring to tell you that the demand for emergency pathways is very high. It has increased significantly. Currently, 855 emergency cases per 100,000 are registered in our emergency department across the country. And 855 per 100,000 is a huge number. In terms of road crashes, we have an increment of about 3 times, that's 300% increment from 2015, 2016. We moved from 56,000 to 164,000 in 2024. And the motorbike or border injuries are accounting for 56%. To drive it home, utilization of ambulance services has also increased from less than 2% in 2018 to 21.4%. But you know that in the target, we must be able to address all the patient needs. Again, there is increasing burden of non-communicable disease, cardiac, cancer, and diabetes. You saw what Dr. Kaguna was presenting here. And our paramedics have reported that the absence of appropriate referral pathways have led to duplicated and unnecessary processes, which consume a lot of time and reduce efficiency. Because sometimes someone calls you and you are reaching there, and really there is this patient did not need probably to move ahead. This is describing from community. Again, for emergencies, we start from the scene of emergency where the first responders or bystanders are able to provide first aid. Then we use the 912 call system where we receive the ambulance teams. The ambulance teams respond to the scene, they triage and give the care. and then transport the patient. And these patients are transported and received at the referral facility for definitive care. Now, what is unique in the emergency referral pathway is that time is critical. And referrals should bypass some levels. When you get an emergency referral, don't ask so much that why did you leave the other place to the other. In referrals, so long as people establish that the next facility does not have a doctor. If for instance, let's look at the obstetric emergency. If a midwife calls a health center and realizes the doctor is not there who always does the cesarean section, she will just send that patient direct to the regional hospital, and someone should be able to receive that. And when a patient has maybe like an acute coronary heart disease, he may move directly from a health center to the national level, because it is not, any time you lose in the process will be very dangerous. And we have some of the emergency lines, 912, Uganda Red Cross, Kampala project, all these have been spelled out. Now, this is a representation of those movements, the vertical, the diagonal, all those movements across. From down, you can see the community level, you can see government, you can see private. The biggest two areas is government and private. And all of these are important. Someone asked a question if private can go to government. From that, I think you are able to see that they can move across systems. And when they come to government, don't say for you have money, why do you come here? No. All of these are Ugandans who are supposed to utilize these services. Continue. The upward referral, we have already described this, where we are moving from community to health center 2 to 3 to 4, general hospital, and up to the referral, national referral and specialized. Then the downward referral is a reverse of what we have described up. And this step down referral is in case a patient has stabilized. You refer a patient to Dr. Peter here because you want a major operation. You want maybe a total abdominal hysterectomy. After he has done that, after a day or two and the patient is stable, can send him back to you at a health center for post-operative care, and you should be able, it is a step down. Then the horizontal, again, we described this, and the last bullet, we emphasize that it can be from a public health center 3 to a PNFP health center 3. I just wanted to make that clear that we are to work together. I've seen nowadays people are trying to say private, public, no discussion. No, all of these are for patient care. What makes our systems break down, especially the pathways, is lack of guiding documents, standard operating procedures, distance and transport availability, costs at facility level, communication gaps. This was emphasized so much by Dr. Kaguna Yusuf in her presentation. Insecurity. Sometimes if there is insecurity, you may not be able to really follow the pathway as required. Provider confusion. This one is in the sense that the provider himself or herself doesn't know where to refer you. So he just writes the referral and it is you to find where to go. Now we need clear protocols. We need functional communication lines, the way you saw Mbale was showing us some of those. Those are not everywhere. We need transport systems. You saw ambulances. These tuk-tuks are community transport systems, which are innovations. You saw the issue of fuel pooling. We need also a feedback loop The receiving facility should send back and tell you what they did with your patient and what you should be able to do yourself. We need to inform the community to know what services we can be able to provide and at which level. Now, referral protocols. These are step-by-step rules for when, how, and who refers a patient. We did the support supervision to some health center force. We realized that midwives and nurses were referring critically ill patients, and what they put there is doctor is absent. That's not right. The doctors should be present to refer this mother or this patient who is critically ill, and they should be able to communicate with another doctor that I'm referring because of ABCD. Then we also need the referrals help us to ensure that we are timely, we are safe, and everything is documented. When to refer, we take that decision, and immediate referral is important. We must, especially emergencies, we must refer them timely, because time lost means the outcome will be bad even when they reach the referral hospital. Then who can initiate referral? It depends on the level. If it is at community, it should be a CHU, a VHT. If you're in health center 3, a nurse, midwife, or clinical officer. If you're at a higher level health center 4 above, then that duty is put to the highest person there. If it's a medical doctor there, he should be able to refer. If you are coming from Mbale Hospital to Mulago, then a specialist in Mbale Hospital should be the one to refer, not a nurse or a clinical officer in Mbale Hospital. Dr. Kaguna described this, I think, in detail. Let me just quickly pass through that. The first step you must take is stabilize your patient before you refer. Never refer a patient who required something small to survive, and you say, we're younger. If a patient is bleeding, stop that bleeding, because he will bleed, and by the time it reaches the next site, probably would have passed away. But again, the warning there is don't wait to make your resuscitation perfect. Don't wait that until it is very stable. That is when you know. Do what you know is life-saving, and the patient moves. You need to establish the need for referral. You need to facilitate and coordinate your referral. You saw what Dr. Kaguna was telling us about communication with the other facility. You need to fill those referral forms completely. You need also to prepare the patient and family. Again, Dr. Kaguna told us the other patient, it was done very well. They talked to the family and arranged. You need to arrange transport with your ambulance coordinators, and you also, the receiving facility needs to send back feedback. So all those steps must be in continue. Now, there are important referral process tools which we must utilize, and the mandatory ones are outlined there. A referral form. In the next one, I asked Dr. Jimmy that there should be one where we go through this specialist pass through. How do you make that form complete? The referral register, how do we fill it? Maintaining a referral directory. Most hospitals don't have this. Filling the call and dispatch form. Filling the consultation request form. This is usually from one specialist to another. The ambulance patient care form, the patient handover form, the referral form for management of patients abroad. The first ones, you can ignore the last one because it's done at the national level. But all the other tools are very important to all of us who are managing at facility level. Now, what do we need to have in place? Triage protocols. The UTAT I think Dr. Nate did a lot of work some years back. I think when she was still working with the Ministry of Health and Seed Global here, and that too is important. It is in every facility, but the problem we have is that people don't use it. I interviewed some of the health workers and I realized they have it, but no reference to it. So we need to do some training. The mass casualty triage system and also what we use in transport, clinical management protocols, destination determination protocol, the handover protocols, interfacility transfer protocols. All this, we need them. Now I will take you to the call and dispatch system. This country is in the process of developing this system, and the emergency medical dispatch system is used to coordinate fast, accurate, and emergency life-saving steps to save life. The first step is receiving emergency calls. The next is to assess the situation of that call, to prioritize the call and dispatch the most appropriate ambulance or medical resource. And usually this is utilized, the people in the call center are call agents and medical dispatchers. Now, why is emergency medical dispatch important? Time sensitivity. It helps you to rapidly respond. The right resources. You saw Dr. Kaguna was telling us they used the type A. For that, very sick, that patient was quite critically sick because for a DM to start losing consciousness, then you must know what resource to use. Then because it is standardized, there are fewer errors committed by us. You save life, and it also links with the community. In these ambulance centers, we have, our plan is to have 17 of them. One is the national level, which we are going to set up. Other 16 regional level. We are already in the advanced process of having about 8 of them function. And their responsibility is receiving calls from the public, collecting essential patient and scene information, dispatch ambulances, pre-arrival instruction, and coordinate patient transport. Now, the regional level is very key, and we put it here so that you can be able to see what we are looking at in terms of development. The medical dispatch system is a centralized system. It operates at national and regional level. Now, the main operational site is the regional call and dispatch center. And as you know, we have established one in Arua, one in Ilila, one in Mbale, Jinja Small. Here in Kampala, we have in Mbarara, and we are also setting up in Yumbe. These are going to use a computer-aided dispatch, which has an automatic vehicle locator system. It has a geographical information system. It also has a real-time fleet status, and it links urban authority EMS person. It also links to police, fire, works, marine, and air. We also linked with the Office of the Prime Minister in response to disasters. You have seen us respond to Kasese, Elgon disasters. We responded to water accidents. Those we do through the Office of the Prime Minister. Now, a little thing about the 912. 912 EMS Uganda is going to be our main ambulance shortcode call number. And all of you, when it's fully functional, you are going to be happy to say we have set up here in Mulago, and the calls are free. It is a 3-digit number, and it is going to have national coverage, and it directly connects The three major networks are two, Airtel and MTN. And the Airtel and MTN, when we assessed, it covers, I think, 97% of the country. The network penetration is 97%. So we think we can reach almost all Ugandans. Single universal emergency number linked with the 99, and it automatically routes to the regional call center. And we have trained dispatchers who handle this. And it is ambulance to hospital radio communication system enabled. So that these issues which we said, oh, no pre-notification, to become something of the past. Next steps, we need to finalize and disseminate the national referral protocols for emergency conditions. We need also to finalize referral pathways to support patients. We need to operationalize the 14 call and dispatch centers. We need also to train paramedics and call agents in the medical dispatch process. Dr. Kalanzi and team, they managed to develop for us a course, and which we are going to start training. We need to train all ambulance crews, dispatchers, emergency departmental staff on standardized referral procedures. These things we are talking about, they look easy, but if you don't teach people directly, then we shall continue having these problems we are having. To implement to ensure that the patient care forms are used, then the ISBA handover, to strengthen interagency linkages, also to monitor referral indicators. We are trying to have these indicators reflected within the DHIS system. We have Uganda referral guidelines, but I realized they have not been widely disseminated. And when I reviewed them, I realized they are a bit outdated. There are things which are not there. So we need now to review them again so that we can update ourselves and disseminate widely. And since now that we are in the NDP4, it will change the status quo. Then, of course, the last thing is that quote from some of the gurus who have managed patients over a long period of time. I started to think that this makes a little bit, we say to truly improve the patient referral experience, we must understand the patient's journey from the patient's perspective. Patient's journey from patient's perspective. We need to understand that. If we do that, we shall be in good business. Thank you so much, Mr. President. Good.
Wow. Thank you so much, Dr. JB. And those virtual claps are coming to you live from over 400 participants we've had on this session. I need to emphasize that this is the 7th sitting of 2026, but the 115th session, ECHO session. We are glad to be hosted by Seed Global Health. Ladies and gentlemen, you've heard it from the horse's mouth, from the Commissioner, Emergency Medical Services, and we are glad that we had the Commissioner in our midst and try to demystify some of the things that, and definitely some of the expectations that you had here, and I think Commissioner has ably been able to talk about. Can I hear some questions? I can see colleagues from Kenya, from Rwanda, and the rest of Africa. Thank you for joining the call. Andrew Okilo, please unmute and let's have your question or concern.
Hello, I hope I can be heard. Yes, thank you so much and good evening everyone on call. I just wanted to share a small challenge with the LMNS system. Because most times whenever there are referrals happening, the LMS system communicates within itself, and then the EMS system is kept out in the communication. Then after the decision has been arrived at, without our knowledge and all the things, then EMS is just looped in at the end of the discussion. Maybe let's say, for example, go pick a mother from Kawempe going to Women's Hospital. So we don't have all the details about the patient and all the things, just a few things about the patient and stuff like that. Then when EMS arrives on ground, it is just picking new information that you could not get from this part. You just get it on at the scene. And then as that also matches with an aspect of sometimes we get when the referral facilities maybe wants to refer a patient in the morning. Then because of the delays that happen, maybe with the preparing the ICU bed and things like that, over time the patient's condition changes. Now, when EMS is now ready to go, when they notify the receiving facility maybe notifies that now the bed is ready to bring the patient. Sometimes you arrive when even the condition has changed, and most times EMS is introduced at the last moment. So maybe I don't know how the LMS team can comment about that. And then lastly, I heard Commissioner talk about the regional referrals, housing the call and dispatch at regional referrals. How about national? Thank you.
All right, thank you so much. Let me take another hand from Chirabo, Mika Frederick.
Yes, hello. Thank you, and I would like to appreciate the efforts. I have one question, but I would first of all wish to thank you for the concerns raised here, because I once had that experience with our regional hospital when I was working with the ambulance team. There's a time when we could refer patients, but when we reach at the referral point where delivering the patient, they give you hard time. They want to toss back at the patient, telling you, why did you refer here? Why not the other center? They are saying, you didn't manage the patient, just referred, but they tell you this was not done. Why not so? So they keep on blaming the team that delivered the patient, which wouldn't be at that very time important. So I thank you for addressing those concerns. But now I would like to know, you talked about the 912 system, that call system. When do you expect it to start working, and when can we have that service on board? Thank you very much.
All right, thank you so much. There is our panelist who has been getting all these questions and noting them down and answering some of them. Can I have a chance to also engage Dr. Marion? If we have any questions, thank you.
Moderator, but there's I've been answering most of them, but there's a question to the commissioner. It says that now that we have the EMS policy and double funding, what should we expect from your department in this coming financial year with regards to actual implementation of the policy? What are the targets that the population should expect? That is the question to the commissioner. I think the rest were about LNMS, and we are trying to sort that out. There's another question to the commissioner as well about ambulance maintenance in Amoria General Hospital. The ambulance's roof is leaking, and it was donated by Tesla Affairs. Is there an answer to that? And the rest have been suggestions and a few questions here and there. Thank you, moderator.
Thank you so much, Dr. Marion. You're doing a great job that side, and we are grateful. Can I have the last maybe question from Kilili Debo Roy? kindly unmute and speak to us.
Okay, thank you. My name is Kilili. I'm a registered nurse. One of the challenges with the referral system, as most of us know, is that the police, most of the cases, uses its cars to deliver patients who have had severe injuries, maybe from road traffic accidents to nearby hospitals. But the biggest challenges we have especially experienced is handling of these patients while at the scene and while transporting them. That in many cases, during transfer, the patient instead just gets worse. For example, observing things like manual inline stabilization of the neck. So there's a big challenge there, and I think there's a need to train those police and other individuals who reach these patients before the medical team arises. Thank you.
All right, thank you so much. I realized that before I stop to the questions, maybe I should stop with Sylvia. Sylvia, have your question quickly, unmute and speak to us.
Hello?
Yes, Sylvia. Unfortunately, we've lost Sylvia. Let me turn back to my panelists for the day. You've had about 400 participants on this call, and we cannot exhaust every question, but Dr. Marion has been able to respond to some of them. Yeah, we had some questions to you, Dr. Peter.
Yes.
About the elements.
Yes, thank you. And the member asked that LMNS, when there is a problem in maternal and child health, the teams coordinate amongst themselves, and the emergency ambulance system comes in later, and they find out different information. So it varies from one LMNS to another, but the LMNS is some sort of an emergency response unit, by the way, how it operates. So it doesn't have to be separate from the emergency ambulance coordinator of that region. And actually, even there was a platform where some referral notes are posted, or some of those cases which are being referred, the emergency ambulance coordinator of that region should belong to that LMNS platform. And from the guidance of the Ministry of Health, in terms of LMNS strategy, the emergency ambulance coordinator of that region is a member of the secretariat and must know whatever is happening. And like specifically for our region, we have even distributed the number of the emergency ambulance coordinator of the region to different health facilities through the platforms. So if they have any case to refer, to be referred from maybe a health center to the regional referral hospital or the general hospital, actually they call even live to him and is able to guide on the response and is able to provide them with the appropriate vehicle to transport the patient to the referral site, and the care is given. So actually, there should be no separation. They are the most important people to utilize these services. Thank you so much.
All right, I could allow Commissioner to respond to some of the questions.
Good. Thank you, Mr. President. And thank you, all of you, the active participants, for all your questions, your active listening, and so on. I will, the first one is on the National Call and Dispatch System. We have a unit right now operating in the on the building of the National Public Health Emergency and Operational Center. It's not a comfortable site, but it started there. But going forward in the next this next period, the next 5 years, we would like to have a national EMS coordination center on the hill, on Mulago Hill. We have secured the land there. We are now in advanced stages of looking for resources. We want to have a full-fledged EMS coordination center up there. So this is work in progress, Andrew. Then was it Chirabo on when the 912 system will be functional, fully functional? We have started, and we think that by close of this year, we should be able to have reached maybe over 50% functionality. But full functionality requires that we have also set up other regional call and dispatch centers, so that will take us to DC Kisanja. The president called this Kisanja no sleep. Yes, Kisanja no sleep. By the time we start sleeping, 2030, everything should be very okay. And then Dr. Marion brought some issues which came in the chat. The increased funding. We are grateful that it has increased, and now we say we are going to serve better, and we think that we shall repair more ambulances. But my warning is that we should not be driving excessively and cause unnecessary accidents. It reduces the resources we have. We think that this money will be available for fuel. It will be available for the people who work in the ambulances. It will be available for training. We need capacity building for our health teams. It will also be available for other new functions which are coming, especially the aeromedical ambulance service system. So we shall keep communicating. This will require another session for us to discuss what is there in stock for EMS in the next coming 5 years. And I think, Jimmy, you will organize that so that we tell people what we have in stock. Amori Ambulance, please communicate with Dr. Marion. She's on the chat, and give the details. Then she can provide. Don't wait for these webinars to communicate something which requires operational response. Please be proactive. Then we can see how to help you, because that's why we exist. Then about police, I think the suggestion is clear. We need to train. And Mr. President here under Apple has done some good work in training. Basically, EMS, we want to say we have done a lot through these great partnerships. And I think that was the last. Thank you so much.
Thank you so much, dear panelists. It's been a great day for us and each one of you, I hope. And we say thank you to our participants who have logged in from South Africa, from Rwanda, Kenya, and Uganda. And of course, we can't forget those who have been logging in from the rest of Africa. Thank you, and this has been the 7th session this year, but the 115th since we started the EMS ECHO here with City Global. We thank the panelists, and we thank Minister of Health and other partners that have made these sessions really interactive. Your parting shots, Commissioner?
Yes, I really want to thank you, President. I thank City Global. I say let's continue to interact on this topic on referral. is very, very key area. It's a missing link. All the care can be okay in one facility, but during that process of transfer of care, everything falls apart. So you have started a good line. Let us all work together and improve the referral system. Thank you.
I can't say it any better. He has made it, and I can't speak anymore. It is 4 p.m. here in Uganda, and
You can put on their videos.
you can put on your video such that we see you right now. We can tell where you are. All right.
We are taking screenshots and smile.
Smile.
Can I have some smiles, please?
Yes, Herbert from Life Care Clinic in Gwengo.
All right. Do you have somebody from Kenya?
Yes, Tom. Thank you very much. This team is from Kenya. Thank you for the invitation.
Oh, the president of KCMT from Kenya. Good to hear from you.
Yes, nice to hear.
Commissioner should be happy that you.
Hello, Mr. Commissioner. Nice to see you.
Good, nice. Thank you so much for attending, my dear.
Okay.
All right. Bye-bye, everyone.
Bye.
Bye.